Welcome, everyone. Thanks so much for coming to our webinar today. Today we have Doctors Marie Bakitas and Nathan Goldstein here to talk about getting to the heart of the matter, how the PCRC Heart Failure SIG has integrated palliative care research into heart failure. Just a couple items before we get started. We ask that you submit all questions to the Q&A feature, which is a button at the bottom of your screen. If you type in questions, we'll be able to answer those periodically throughout the webinar, and we'll also have some time for Q&A at the end. If questions that come up are more technical in nature, like if you're having trouble hearing, we ask that you please use the chat feature, and we'll do our best to help. All of our attendees are muted and video cannot be turned on. And today we have Dr. Christine Ritchie representing the Executive Committee of the PCRC. And I think I'd like to get started and ask Dr. Ritchie to introduce our host speakers.
Wonderful. Greetings to everyone. We're so glad that you've joined us for this webinar, and so grateful to our presenters today. Dr. Marie Bakitas is a professor and Marie L. O'Corin Endowed Chair and Co-Director of the Center for Palliative and Supportive Care at the University of Alabama at Birmingham School of Nursing and Department of Medicine, Division of Geriatrics, Gerontology, and Palliative Care. She focuses on developing and testing novel interventions that improve palliative care access and reduce disparities for persons with serious illness and their family caregivers. And she's done a lot of very innovative work in rural areas in particular. She's tested innovative methods such as telehealth and teleconsultation to reduce health disparities in the Deep South among minority cancer patients and family caregivers through an NCI-funded implementation trial in 48 cancer practices across the U.S. Since 2011, she's extended her work to advanced heart failure patients and their families via numerous pilot studies, one funded by the National Palliative Care Research Center, and a recently completed NINR-funded R01 Enable CHF-PC RCT of a concurrent heart failure palliative care intervention for rural older adults and their caregivers. Dr. Bakitas has published over 100 original database papers, book chapters, and books. She's a fellow in the American Academy of Nursing and is also a palliative care nursing fellow from HPNA and an all-around wonderful individual. Dr. Nathan Goldstein is a professor in the Department of Geriatrics and Palliative Medicine at the Icahn School of Medicine at Mount Sinai. He's a clinician investigator whose work examines patient-physician communication in patients with advanced heart failure, work that's been funded by the National Heart, Lung, and Blood Institute and the National Institute on Aging. He's also the site chair for the Department of Geriatrics and Palliative Medicine at Mount Sinai, Beth Israel. Also responsible for a lot of the content today and who you'll be hearing more about from Dr. Bakitas and Dr. Nathan Goldstein is Dr. Laura Gelfman. And she received her medical degree from Mount Sinai School of Medicine and is a faculty member there in internal medicine and palliative medicine. So we'll turn it over to Dr. Bakitas, and thank you so much to both of you for serving as our panelists today.
Great. Thanks so much, Christine. I just wanted to comment quickly on the slides on the screen. Apparently it says I am the director of the Agency for Healthcare Research and Quality Center for Evidence and Practice Improvement. That is absolutely not true. I don't even know how that got on the slide. So let's just move to this next slide where things are a little more correct. So thanks to everyone who's joining on the call today. Marie, Laura, and I are really thrilled to have been both part of PCRC and been asked to present this webinar today. You know, the PCRC, and we'll talk about this as we go through the slide set, about how incredibly helpful it has been to become part of PCRC as a SIG, and particularly the backing of NINR behind PCRC, but we'll get to that in a few slides. As Dr. Ritchie mentioned, the three of us have been working together for several years. I really did want to spend just 1 second commenting about Laura Gelfman. So unfortunately, Laura has a family emergency and can't be on the webinar today, but I want to be clear, and that's why I made this bold and in red. I wanted to be very clear that while Marie and I are thrilled to work with Laura, she's the brains behind the outfit, the drive behind the outfit. These slides are all hers that Marie and I have been commenting on. So so unfortunately, even though Dr. Gelfman isn't here today, I really want to make sure that folks understand that all of the work that we're really going to be talking about could not have happened without Dr. Gelfman and her drive and determination. And we're sorry, she's very sorry that she couldn't be here, and sends her apologies to all of you. So, of course, we want to thank all of our funders, and as we go through the talk, we'll spend a little bit more time talking about each of these. The other piece to talk about is these are the funders who have really worked with us and our heart failure impact group. Obviously, there are many other funders of PCRC and each of our research as well, particularly, again, thanking NINR for the work that they've done for PCRC and thereby helping us as well. But these are the funders that really have helped in terms of our work and the work that we're presenting today. So quickly, we'll talk a little bit about why we need a partnership between palliative care and heart failure. And then I will hand it over to Marie, who will talk about the initial funding and structure of our program, why we developed a symposium, what that was, what we accomplished from the symposium, and then nearing the end, I'll take things back to talk a little bit about why we chose to become a heart failure SIG within PCRC and some of our lessons learned. So the first question is, why does integrating palliative care into the care of patients with heart failure really matter? And for those of you on the webinar who are very familiar with the integration of heart failure and palliative care, this will probably feel like a little bit of review for you. So the first question is, of course, what makes heart failure different? And the trajectory on the left is the cancer trajectory that we're all familiar with, where folks have a sustained period of good function for a period of time, and then they quickly have a drop in function as they're approaching death. Heart failure and other end-stage organ failures, of course, have a very different model where patients have a period of exacerbation and they'll get a little bit better. And each time after exacerbation, they will get better, although their level of functional status does not get back to what it was before. And so they do have this progressive decline. The real question, of course, is at which exacerbation will be their final exacerbation. So in folks with cancer, once they begin to have this rapid decline in function, you can actually predict prognosis and life expectancy pretty well for those folks. But when we look at heart failure, the trajectory is so different that it can be very difficult to know at which point a person is in their overall trajectory. However, it's gotten even more complicated these days when we think about heart failure. And as this patient is saying to their clinician, I'm taking better care of my heart, I started using aspirin as one of my pizza toppings. And the model of caring for folks with heart failure has completely changed over the last 10 to 20 years. So it's no longer just giving people a few medicines to try and make their heart pump a little bit better. Now we think about it in terms of these large categories: replace, remodel, reprogram, and repair. And so what used to be a field really predominated by medications is now equally predominated by devices and, of course, transplants. This is perhaps best summarized on the diagram on the right, which is from Sarah Goodland and colleagues. And what you see is, in many ways, it looks like the standard heart failure trajectory, where you have sustained function, and then you have periods of exacerbation over time. Here, where you have periods of decreased function over time, and then the patient's ultimate death. The thing that makes heart failure so different is, one, these particular lines, which are these sudden death events, where at any moment the patient can die. And of course, it's really this model, this line, that makes this trajectory so different. So with the advent of transplant and ventricular assist devices, the way we think about prognosis and trajectory in these patients is completely different than it was even 20 years ago, and makes it so different than other illnesses such as liver disease, lung disease, and cancer. Because while transplant is an option for some of those folks in each of those diseases, the technologies within heart failure really makes the way we think about integrating palliative care into heart failure a completely different model. This is actually shown well in this diagram. At the top, you have kind of the early days of heart failure, where folks progress from stage B to stage D to stage D, and ultimately to heart failure death. And so while they did have an unexpected to expected death, that was the way it was for a long time. However, the bottom of this diagram sort of looks at the present day in terms of the treatment of heart failure. What you see, of course, is the addition of these kind of backwards lines, that is being able to move people back in the trajectory of heart failure. And so at any one time, patients are simultaneously at the risk of dying and also have treatments that can reverse or completely change the heart failure trajectory. And now we're seeing more and more folks, of course, are dying of heart failure, but we're actually able to manage their heart failure better over time so that they're actually dying from other comorbidities. This was not thought of even 20 years ago. We know that the prevalence of heart failure is increasing over time, particularly as we have an aging population, much better improved survival after heart attacks, and much improved survival in terms of heart failure itself. It's been projected that by 2030, more than 8 million people over the age of 18 will have advanced heart failure. And so what I'm trying to do here is set up for you why heart failure is so different and why we need different models or different ways of even thinking about ways to integrate palliative care within heart failure. This is the standard ACC-AHA practice guidelines approach to heart failure. And what we've shown here is basically stages A, B, C, and D. And the majority of us in palliative care see patients at stage C or D. But one of the things that we often talk about is that how we in palliative care think about heart failure is different than the way that cardiologists and heart failure specialists think about heart failure. This is particularly true at the top of the pyramid, where the palliative care says it's time for end-of-life care planning, and heart failure says it's time for VAD or transplant. What's probably true is that it's all of the above, and adding in a little bit of advanced care planning as we think about how we work with patients to get them through these difficult times of decision-making. But the point here is that we decided that the best way to tackle these kinds of questions and these kinds of ways of different views of heart failure and how we treat it is to really incorporate and bring together a group of cardiologists or heart failure specialists, not necessarily cardiologists, and palliative care clinicians together, literally in the same room, to begin to strategize. And we know that in general, NIH funding for palliative care and heart failure has been relatively low. Of the $45 billion of NIH funding for heart failure, only about 13.6 million went to palliative care. And this is work that I had a medical student do several years ago that looked at research back up until 2013. So these numbers are a little bit better, although the trends are probably still the same. It was less than 0.1% of NHLBI funding. And when we look particularly in terms of publications, we found that less than 2% of heart failure sessions at national meetings or articles in major journals had a palliative care focus. While NHLBI is the largest contributor to heart failure research, less than 5 million of that money per year goes into palliative care. And of the 4.7 billion in heart failure in NIH funding overall, only 26 million went to palliative care research related to heart failure. And so what we've done at this point is hopefully lay out a little bit of why we need to think about this in a different way and some of the scope of the problem. And now I'm going to turn it over to Dr. Bakitas, who's going to talk to you about some of the steps that we undertook as a group to try and begin to change the way we think about integrating palliative care into the world of heart failure.
Thanks, Nate. And this is our initial proposal was actually led by Dr. Gelfman. So I'd like to emphasize, the key role that she had and how Dr. Goldstein and I are both representing a lot of her work. So on the next slide, you see that the original proposal went to the John A. Hartford Foundation and AFAR, the American Federation for Aging Research, the Center of Excellence program. And the initial proposal actually was going to focus on how to develop a communication skills model to improve communication of heart failure clinicians with older adults with heart failure and their family. But we soon realized that this was a bit narrow, and Dr. Gelfman invited me because we wanted this to be an interprofessional proposal. So I and Dr. Goldstein were her mentors on this proposal, but she was the lead PI. And so when we thought about that, we had to just figure out how to broaden it. And so we did get some supplemental funding from Hartford and NPCRC, because really what we wanted to do was catalyze practice changes on a national level to improve quality of care. Next. So where did we start? Well, the first place we started was to gather together heart failure and palliative care clinicians together nationally by way of this process called a nominal group technique. And what NGT is, it's a bit of a qualitative, sort of a mixed method that can be used to get some preliminary data. And so we did phone-based NGT sessions, getting input from a structured format, getting input from cardiology and palliative care clinicians. We had 10 cardiologists and 6 palliative medicine experts, and conducted 3 groups. And what the idea was, on the next slide, was to identify sort of 3 areas. What were the challenges that patients faced, the evidence, and the models, the evidence that was needed in the models. And so our results from these first groups, you can read what's on the slide here about the challenges that people faced, clinicians faced in their care of heart failure patients, and how could palliative care help. And so from symptom management, goals of care, improved cross-training, the issues about prognostic uncertainty, which we all struggle with, palliative care myths, etc. So these were some of the challenges that were being faced. On the next slide, we were really curious about what evidence was going to influence you and your colleagues about the role of palliative care in caring for your patients with heart failure. And what they saw was a lot of guidelines from heart failure were coming out with recommendations that, number one, weren't based on a ton of evidence, and also weren't being put into practice. And so what they wanted to see was how the guidelines were being were translated into practice. They wanted the guidelines to be mandated, better symptom evidence, and some consensus on a care model. And so we knew that these were the roads that we had to pursue in order to make some progress in this group. What models have been successful? So people had done a number of models where integration of palliative care and heart failure had been successful, from doing triggered consults, embedded clinics, primary palliative care models of training nurse practitioners, home care. And really, the bottom line for all of this was trust and relationship building between palliative care and heart failure clinicians. We heard many anecdotes about how there had been some consults that had gone really well, and all of a sudden, heart failure clinicians started calling palliative care earlier and earlier. So we took all of this evidence or this information and used this to develop this symposium, which was really more of a 2-day retreat workshop where we had trigger talks, but most of the work was done in working groups and discussions. We thought it might be a little bit less expensive to do this in Birmingham, Alabama. And also the food is better than New York City. Nate, I'm sure, is going to jump in on this one.
I'm being kind, Marie, because we're in public, so I'm just going to let it go.
But we thought that it would really be funny to offer cardiologists nothing but barbecue for 2 days. And so we just told everyone to just load up on their statins and join us. So there were 17 physicians, 5 nurses, 2 PhD health services researchers, and a social worker. And you can see that, again, it was a very diverse interprofessional group. Also, many of the specialists sort of doubled as palliative care and geriatrics, or cardiology and geriatrics. And so I want to mention that pretty much everybody was also geriatrics besides the specialties that you see there. And so what did we do at this symposium? Well, we first had our mission, and as I said, that the AFAR grant was broad and beyond communication, we really stepped it up and said that we wanted to create an agenda for change related to research and clinical priorities. And so that was our mission, was to consider what would the national agenda need to be to advance integration. And so we looked at research, clinical models, and health policy, as well as how could collaboration and funding be expanded. So on the next slide, you see that the overview of the 2 days was, as I said, there was trigger talk, small work group, and reporting back. And so the first trigger talk was on research, and day 2, we continued on research because it was only a half-day session on day 1. Day 2 was all day, and session 2 was on clinical models, and session 3 was on quality metrics and policy. And then on day 3, we came back, Dr. Gelfman and Goldstein and I sat on my front porch in Birmingham, Alabama, and summarized all of these sheets of flip charts about, what were the conclusions from each of the groups, and developed an action plan. And that was on day 3, and it was fun. These were the participants, and so I'm sure that those of you on the call can see again what a diverse group that we had, and we want to thank them. They are also listed as well in the publication. So if you want to continue. The goals generated from the symposium was, again, consistent with our mission that we wanted to create a shared research agenda, promoting awareness through publications, presentations, and community awareness. And I think that we were able to accomplish the first 2. The third one, community awareness, is still, really one of those areas that I think we're making inroads, but, wasn't as successful at the end of the symposium in our future work. To stimulate new funding mechanisms, and so to approach funders to improve funding, and as Dr. Goldstein shared how limited the funding was, and there has been an improvement, but still we have a ways to go. And also to form research collaborations between cardiology and palliative care, with involvements from all specialties, including primary care, and for encouraging policymakers to change incentives to encourage doing the right thing, and creating quality of care mandates for patients with heart failure and other cardiac conditions, that would be funded. So where did we get to? Well, first let me just say, so these were, this was our future agenda that we generated. In the research, what we felt were the 3 big areas that needed attention were what's in the syringe. And of course, this is not only unique to heart failure or cardiac disease and palliative care, but what were the necessary essential components that heart failure patients needed to have benefit from palliative care. What were the symptoms that were the most troublesome that palliative care could have more input into? And then what were the methods that we needed to use to study these areas? Because really, an RCT isn't the solution, even though it's considered the gold standard, to study every type of care model. The clinical models that we sort of focused on were really a tertiary care model where you had embedded palliative care, but also really the importance of primary palliative care. And so how could training and education of cardiologists and as well as primary care specialists focus on, what were the basic skills that they needed to offer this primary or generalist level of palliative care? And then in terms of quality metrics, were goals of care discussion and distress screening were 2 areas that were really much more common that to have some very basic quality metrics. So in terms of what's in the syringe, and I've said a little bit about this, so I'll just let you sort of read what's on the slide. You know, again, what were the components? What were the outcomes? What were some of the pharmacologic and non-pharmacologic actions that palliative care would take? And the next were, in terms of the symptoms that the group really focused on were, you know, like the symptom clusters. So, you know, having, you know, edema, dyspnea, pain, together that were refractory to some of the heart failure treatments. And whilst dyspnea is not refractory to, for example, you know, doing diuretics and so forth, that doesn't, you know, necessarily take it away completely. And so we had a lot of engaged discussion about that. What were some of the pharmacologic and non-pharmacologic therapies? Some of the heart failure and non-heart failure related symptoms, who were going to treat them and who was going to teach. And, you know, it was more than just getting with the guidelines. How are we going to teach about symptom management in general, more so than the, you know, the limited areas that are very heart failure specific, focused on getting with the guidelines. And then in terms of our methods, as I said, although RCTs are the gold standard, there were a number of other areas that we thought were important methods to use to look at this complex care model. This was our working group structure for the symposium and thereafter. And I also want to point out at this time, we had, of course, in every cardiology and palliative care study, you need an acronym. And so we developed the acronym for our working group, since saying the long title of what this was all about was pretty cumbersome. So IMPACT stands for Improving Palliative Care Therapies for Patients with Heart Failure and Their Families. And so the F times 2 is heart failure and stands for heart failures and families. The steering group was Dr. Gelfman as the lead, with Dr. Goldstein and I as her backup group. In terms of the research group and the clinical models and the quality metrics and policy, we tried to have a palliative and cardiology member join, you know, be the sort of leads in each of these working groups, and one of us from the steering group was the translator back and forth. And so what were some of the products that this group has produced and publications? Well, so products. First was publications, and here is a list of some of the publications that were stimulated by the symposium, and had not every member was part of every single one of them, but we did try to have most of the members. And the State of the Science up in the upper left-hand corner really was sort of the main publication from the IMPACT working group. And so all of the team members are listed on that publication, all of the symposium members. And what came out of it also was we were approached by Hunter Groninger, who was going to be guest editing Heart Failure Reviews, an issue of Heart Failure Reviews. And so he approached many of the members of the IMPACT HF group to lead some of these papers. And I'll highlight one in particular, and that's the Family Caregiving for Persons with Heart Failure at the Intersection of Heart Failure and Palliative Care, a State of the Science review. There were quite a few of the members formed a working group, and this was a topic that we had actually discussed at the symposium, and it ended up being a perfect match for Hunter's issue. And so this was a working group. I think there was about maybe 12 of us on that particular publication. And Nick Dionodum here at the University of Alabama is a family caregiver researcher. And he led this effort to try to get more support for family caregivers in the heart failure space. So Nate, did you want to comment on any of the other publications?
No, I think I have two comments, Marie, thank you. One is back on some of your earlier slides you were talking about, particularly with the what's in the syringe question and some of these other models. One of the things that's so interesting to me is so much of this is heart failure specific and so much of this is general to palliative care. And one of the things that we have found in this group is this sort of fluidity between what's the general or a natural question that we come up across in palliative care all the time, and what are the questions that are so heart failure specific. So the symptoms is such a great question, or the clinical model is such a great question. There's the what's in the syringe, which is, what is it that the palliative care consult is doing, which is a general question that we ask regardless of the patient that we're treating. But then, as Dr. Bakitas mentioned, then there's also the what's the best treatment for dyspnea and heart failure, which is very different than the treatment for dyspnea and cancer. And so I think that's one of the things that we work on as a group, is sort of going back and forth between these two. The other piece that I wanted to mention is, much of this work has been quite organic, and I'll talk about this nearing the end of the presentation. I don't want it to seem like all of this, became just was born directly out of the work that we've done. Some of it was happening simultaneously. Some of this we're taking credit for other people's work who might happen to have been in the group and are already doing that work. But I do think that one of the things that you can see, particularly from the folks we brought together in Birmingham a couple years ago, and the work that's gone on, is a cohesiveness, a congealing of a group of people in both palliative care and heart failure with a similar interest. So trying not to get too involved in the chicken and the egg, which came first question, but really think about this as the right group at the right time, bringing together folks doing this work. That's kind of all I was thinking about adding here, Marie.
Great, and I definitely echo that. I agree that sometimes when you do a retrospective, it looks like everything was planned out really that way, and there was just so much that was catalyzed by having this group come together in somewhat relaxed atmosphere to just putting all these great minds together in the same room with some space to think what kind of came out of it. And so it's definitely true that these weren't, sort of direct, every piece of this wasn't all planned out, but more of a result of that catalyzing those synergies. On the next slide is the national presentations that were somewhat, one of the things we wanted to do was to say, we should be at AHA and ACC every single year doing something on palliative care. And fortunately, some of the folks in the Impact HF group were leaders and planners for the education for these activities. And so, and we said similarly, at the annual academy meeting, there should be something. And so we set out from the symposium suggesting or signing up for or submitting sessions that would be looking at this intersection. And so even this past year, I was able to present at AHA, though it was on, and Nick Dionodum was presenting at AHA. Still as a result of being invited because we had connections from the initial Impact HF group. Next slide. And also very proud to say that review that was published by Nick in the heart failure reviews issue back then, and these things take time, was submitted to the AHA as a policy statement that should be developed. And lo and behold, it's hanging in there for a number of years. Their AHA commissioned a statement, and that was led by Colleen McAlevin and Lisa Kitko, the co-chairs of the statement, and Nick was a working group writing member, and that is ready to be published in circulation. And so even now, years later, the initial ideas many of them are still coming to fruition, including on the next slide, some of the research projects that our members have been involved in since the symposium. And Laura points out that, this is not a comprehensive list. And so these are just the ones that sort of were, sort of sprang to mind. So in the next slide, you can see 9 trials, including Nate's and mine, and Laura's involved in some of that, in the center there, her own trial. But these were often stimulated or informed otherwise by the members. All of the people here were members of the symposium and the impact group.
And I would just add a shout out again to NINR. Many of these are NINR funded studies.
Exactly. Definitely mine is, and Nate's was as well. Correct, Nate? Am I wrong?
Mine wasn't, but I think wasn't PAL-HF NINR?
Yes, that's correct. Yeah. Yes, that was one of the first ones, and possibly Dave Beckelman's too. So anyway, again, we were sort of focusing very much on, sort of what the original funding did, but you can see that that begot quite a bit of additional work that has then gone on to be funded. And, that's a good idea, Nate, is we should do a review of, some of the numbers in terms of, and different agencies now that have been involved that we've been able to engage with.
Great. I'd like to nominate Laura, Dr. Gelfman, to do that since she's not on the call.
Totally agree. I totally agree. So here are some research projects that are continuing that, again, were sort of directly from that initial HF group. So destination inotropes was one, and Dr. Tim Fendler is leading this. And bless his heart, as we would say in the South, he's worked diligently to get some questions related to palliative care onto the Interpret registry, which Quorum Infusion Company had been soliciting from each of their destination inotrope patients. And so this data is actively being collected now, and more to come on that. The second survey was, we wanted to, the landscape survey, which we're calling, is that this was, has been completed now. We did developed a survey to see what kind of clinical models were out there, because we realized that, a lot of stuff is going on that's not being published. And so we did a quantitative and then follow-up qualitative interview. Maybe some of you on the call were participating in this. We are very grateful for that. And so that is pending submission. The results of that have come up. And then the mechanical circulatory cyst device study, which was, again, a survey of MCS groups across the country, in the Intermax institutions, looking at destination therapy and other topics related to use of palliative care in this population. So, and lastly, Nate, maybe you can take this, speak to this particular collaboration.
Sure. So one of the things that came out of this was, and one of our goals, along with the goals of the National Palliative Care Research Center, was to try and get palliative care research, how do I say this, out of the, into some of the NIH institutes that had traditionally not been doing a lot of palliative care research or not funding a lot of palliative care research. So NIA, NINR, of course, are the institutes that fund the vast majority of palliative care research, and with a very rapid drop-off when you look across the other institutes. So what the National Palliative Care Research Center did was pull together a 2-day NIH workshop in Bethesda in August of 2016 called Advancing and Extending a Palliative Care Research Agenda in the Specialties. And this was actually one of our original goals all along, was to figure out how we get our goal, of course, with NHLBI, to get them to invest more in the palliative care research in heart failure. And ultimately, NHLBI did join one of the PAs that was put out around geriatric palliative care, and that was some work. Although Jim Kirkpatrick and I did the presentation, and what we did was a 10 or 15-minute version of what we've shown you, which is demonstrating the depth of the work out there and the importance of it. And so, again, this is a great example of, I can't say that impact heart failure is the only thing that made this happen, but I think when we were able to stand up in front of all of the other institutes and say, we have this consortium of folks in cardiology and palliative care working together to figure this out, it was a real statement to NIH and to NHLBI that got them to sign on. That was one of the many things that may have gotten them to sign on to some of the work that we're doing. And Dr. Bakitas, if you're okay, I'll just keep going and talking about how we became part of PCRC and where we are now and what it's allowed us to do. Sometimes, as Dr. Bakitas said, things are planned out, and sometimes there's very much serendipity. But as we were beginning to near the end of our funding, we really began to think, okay, well, how can we continue this going, and what do we need to turn this into so we can keep this group of really great people together, even if it is not necessarily with our own funding, and how can we leverage some of the resources that some of the NIH institutes, particularly NINR, have given, as well as the obvious fantastic work of PCRC. And so that's why in June of 2018, we merged what we sort of had been in the past into SIG within PCRC. The benefits are clearly that we now have a platform for research collaboration across disciplines and subspecialties. So by PCRC's allowing us to be folded in, not only do we have the research infrastructure that they have, but it allows us to add another discipline and another subspecialty that encompasses the breadth of all of the work that we're doing as palliative care researchers across the country and really across the world. At this point, much of our work actually relates to what we call work in progress seminars. Now, the original idea, and it has evolved from here, is that perhaps we were not all at institutions that were doing a lot of palliative care and heart failure research. And was there a way to create the work in progress that probably many of you have at your institutions, but on a more global scale, or at least a place where you could have experts from both heart failure and palliative care commenting on your research. So we basically have these hour-long sessions where and in each session, we have a junior investigator presenting his or her work along with a more senior presenter. So the stakes don't feel like they're overly high for the junior person, that they're out there with a more senior person as well. And each person takes about 25 minutes to present their work and opens it to questions and comments from the group. We try and pair a cardiology clinician and a palliative care clinician. So within the same session, you have a junior investigator and a more senior presenter, along with, in that same session, one of the cardiologists or some sort of cardiology clinician and another palliative care clinician. And then as we get to the end, we'll talk about, we have some what we call special topics presentations, and we'll show you some of those as well. So now I'm not going to read all of these slides to you, but I think what this will do is show you the diversity of the presenters who have participated in the work in progress. So you have very, very senior folks in the field, as well as more junior investigators. We have physicians, we have nurses, we have social workers, so a broad range of disciplines presenting their work. And these are continuing along this theme, and you can see it's everything from very specific cardiology procedures to larger questions about decision-making and working with cardiology within diverse patient populations. In terms of the special content presentations, we've had a couple of them. One was a work with promoting our impact heart failure work within the American Heart Association. So that was a specific talk where we talked about ways we can integrate better into the American Heart Association, and spoke specifically with folks at AHA to better understand how we could get integrated into AHA and better work with them so we could, if you will, influence their agenda to include more palliative care. And Dr. Bakitas spoke about that a little bit earlier. And then this was just last month where it became clear on some of the presentations, some of the work in progress, that people were doing a lot of implementation science. And Dan Matlock is a real expert in implementation science, and particularly around using step wedge techniques. And so Dan gave a very nuts and bolts session on how to think about implementation science 101 in general, and particularly around shared decision-making and heart failure. So a combination of people speaking about their specific projects, if you will, as well as more general topics. So as we're nearing the end of the hour, the question is kind of where do we go from here? We are excited to use the resources and infrastructure of PCRC to begin to think more about multi-site research collaborations, and we mean that in lots of different ways. So multi-site, we mean single investigator-initiated studies that might involve multiple sites for the research, but then also thinking about using our network and that of PCRC to pull together PIs across institutions with shared expertise or complementary expertise to think about multiple PI projects, particularly as we're thinking more and more about team science. As Marie mentioned earlier, this is everything from research on symptoms to communication to new models of delivering or integrating palliative care into heart failure. One of the things that we're really working on is ways to continue funding and sustain the group, and we'll talk about that more in the next slide. And then there's a real question about strategic planning and visioning. And the question that I have, that if we have time and then we can talk about, is how much of this needs to be deliberate versus organic? And so what are the lessons that we learned? Well, let's talk about funding. It helps when you have it, but you can make it work when you don't. So as Dr. Bakitas mentioned in the beginning, we had money from Hartford and AFAR and the National Palliative Care Research Center, and we were able to pull together a multi-day symposium that was the springboard for much of what we presented today. At the same time, we no longer have our own funding and are relying on the infrastructure and funding of PCRC, and have morphed our work into the structure of PCRC to really move in a way that we probably wouldn't have even thought we were going to go when we sat down at the very beginning. The second point is something that I've learned much more as I go on in my career, which is basically you have to get out of the way and smart people will do good work. I think Marie used the word catalyze, which I think is a fantastic word. What we did is we brought together lots of people and put them together in a room for a couple of days to just see what would happen. We had an agenda, we had a mission, we had outcomes that we wanted, but much of what happened was not planned, as it often is. And this is really the tension between planning and allowing the process to go where it needs to go. I think when Dr. Gelfman, Bakitas, and I sat down several years ago to think about, well, what do we want this to be and where is it going to go, we would have never imagined that this body of work would have come out of it, or that we are where we are. And I think this is a real tension, and one that honestly behind the scenes the three of us still struggle with, which is what are our aims, what's our strategic vision, and how rigid do we need to be versus allowing the organic process to happen on its own. There's a lot of challenges to doing this research. Again, some of this is palliative care in general, and some is specifically related to cardiology. The biggest one is that cardiology moves faster than palliative care. The industry drive to innovate, particularly around medications, technologies, and devices, is much, much faster than the traditional funding and research mechanisms we use in palliative care. We're designing studies, and the technology is changing as we do. I remember, and I'll give a very quick anecdote, I was doing some work in VAD several years ago, and I was on a phone call with several cardiologists, and one of them said, oh, right, well, okay, do you want to include total artificial hearts in this? And my response, at least in my head, was, oh, we're doing that now? Right? It's very hard to even keep up with where one field is going, where the field of heart failure and cardiology is going, looking at it from outside within the world of palliative care, which is, of course, why we've created these kind of collaborations in the way we have. The R01 is the backbone of academic research. Many of us on this call and in our consortium are academic researchers. Yet the 5 years of RO funding, which is really 7 years to bring the project to full fruition and completion, does not match the pace at which either field is progressing. And by that I mean both cardiology and palliative care. So there's a mismatch between the way we fund this work, or the way that our deans and chairs want us to fund this work, with what's happening in the real world. And finally, there's this question that we all struggle with, which is, who is the target of clinician-centered interventions? Is it the primary care physician? Is it the cardiologist, or is it the heart failure specialist? Is it the physicians, the nurses, the social worker, or someone else? And we spend a lot of time doing work in academic medical centers or in the outpatient practices associated with academic medical centers. But the real question is, what's happening in the general community? That's where the primary care physician or the general cardiologist is taking care of the bread and butter heart failure patient. And while they may not be part of an academic medical center, I would argue that the majority of the work being done in heart failure is actually being done in that population, which probably isn't being tapped in many of the studies that we looked at on the past couple of slides. We don't have the answers for this, but we thought it was a great way of pulling together some of these challenges. And I think this final slide, if you're interested in learning more about our SIG or want to become part of it, this slide will actually tell you how to become part of the SIG itself. Dr. Bakitas, do you want to add anything here at this point? Otherwise, we can turn it over to Dr. Ritchie to moderate any questions that may have come through.
No, I think I'd just as soon go to questions, and we can address anything that's an issue there.
Great. And so on behalf of myself and Dr. Bakitas and Dr. Gelfman, I think we, want to thank Dr. Gelfman for all of the work that she's put into this and sort of guided Maria and I along the process. And we really want to express our sincere thanks to everyone on the call, but particularly PCRC and NINR, who supported PCRC and therefore our group at this point. So Dr. Ritchie, I think we can hand it back to you.
Thank you so much. Thanks so much, Nate and Marie, for an incredibly inspiring presentation. It's amazing what you've accomplished. And just as a reminder to the attendees and participants to use the question and answer feature on the Zoom button to propose your questions. But while we're waiting for those questions, I'd like to ask the two of you how you've been so effective at promoting publications around your work. I've just been so impressed by the number of publications you've been able to generate, and how have you been able to get the group and the community to sort of galvanize around this area and get publications out?
Well, I mean, I can take part of that. You know, we have really tried hard to mentor junior people, and I think that, you know, some of the initiative, if you see some of the first authors on our publications, you know, it really has been, you know, junior people stepping up, and, you know, and I think this presentation is another example of that, because, you know, although Laura, you know, was still considered junior to Nate and I, you know, really stepping up and making the field move forward, and dragging some of us senior people along. So I think the magic is that the mentorship of the junior people has been one of the major ways that I've seen that we've been able to get publications pushed along. Nate, do you have a comment on that?
No, I would completely agree. You know, I think what's been interesting is sort of seeing the senior folks in this group and the folks who started out junior and of course have progressed over the last several years. And one of the most energizing pieces I think has been looking at the junior folks coming into this and sort of seeing, you know, well, there's this group, there's this consortium, there's a place I can go with some of these questions, and then helping them do some of the work. I do want to say, because we don't know who's watching this, some of the work, we are taking credit for other people's work, Dr. Ritchie, and so I think it's really a combination of paving the way for folks, and then I think being in the right place at the right time as the field is moving forward.
Thanks. Well, that's what we all should do, is take credit for each other's work. So we do have a question here. Do you have any advice for those of us who are junior investigators at institutions without senior folks in this field, or even senior researchers in palliative medicine, for how we can get connected to mentors?
Join the PCRC Heart Failure SIG.
I think that is absolutely number one.
Go right ahead, Marie.
I was going to say, because there are a lot of possibilities and mentorship opportunities that Dr. Ritchie leads from the Investigator Development Corps, and so they don't have to be at your institution. You can get a lot of mentorship and a lot of support from the PCRC, from webinars such as this. There are, you know, in-person opportunities. We have the in-person meeting coming up, which is an amazing venue for junior folks to get connected with senior folks, and a lot has gone on after that. So I think that's probably, you know, I mean, that's basically kind of what our, you know, symposium and subsequent work was bringing together junior and senior people from across the country. So there weren't people really there from the same, many from the same institution. So I think joining the PCRC is and our SIG, you know, is really the answer.
Excellent. And I think that's a really important point. The nice thing about the special interest groups is that because they're smaller and because they're topic focused, they give people a chance to sort of connect in with people who are more likely to be aligned with their particular area of interest. So would very much urge folks to consider that as a way to get connected to folks with whom they can sort of bounce things off of and get good questions answered. So in the remaining minutes that we have, one other question for you all, which is, you talked about how rapidly the technology is changing and how challenging that can be. And I'm wondering if you have any sort of recommendations to palliative care investigators on how to navigate that kind of rapid pace for change in the way you interact with some of your specialty colleagues in cardiology.
I'll start with this one, Dr. Bakitas, and then I'll let you answer. You know, I think, Dr. Ritchie, one of the things I do is ask my cardiology collaborators, does this make sense? You know, in 3 years, is this going to be obsolete, out of date? Where should we go with this? And to ask relevant questions that don't matter based on the technology, right? Some of my work has been trying to get clinicians and try and teach clinicians some primary palliative care skills. My work has often been around ICDs, but rather it doesn't matter what the technology is or what technology is coming down the pipeline, the skills are the same, and trying to get them to learn some new communication techniques, I think very much have made changes regardless of the device that we're talking about. And so trying to both figure out kind of where the field is going and where things are going to be moving, at the same time making sure that the lessons we're learning are not device or specific.
Excellent. Well, wonderful, and thank you for going ahead and putting up the last slide. Very much appreciate, again, the presentation by Dr. Bakitas and Dr. Goldstein, And just as a reminder, we have actually another great webinar coming up next week, which will be presented by Dr. Lynn Adams and Karen Kale from the National Institute for Nursing Research on the NIH grants process, idea to submission. So stay tuned. We'd love for you to present any questions that you have to them, to us, and we'll send you more information about that after the conclusion of this webinar. Thanks again, and have a great rest of the day.